Lucky Land Casino, asking people, what's the weirdest place you've gotten lucky?
Lucky? In line at the deli, I guess?
Aha, in my dentist's office. More than once, actually.
Do I have to say?
Yes, you do.
In the car before my kids' PTA meeting.
Really?
Yes.
Excuse me, what's the weirdest place you've gotten lucky?
I never win and tell.
Well, there you have it. You can get lucky anywhere, playing at LuckyLandSlots.com. Play for free right now. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18 plus. Terms and conditions apply. See website for details.
Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, Eric Christensen, PharmD, BCPS, BCGP. And today what I'm going to cover is rivastigmine. Rivastigmine is an acetylcholinesterase inhibitor. So I have covered donepezil. That's another acetylcholinesterase inhibitor in the same class. But I did want to cover rivastigmine specifically because there are a couple of quirks that definitely are different, and I can share my clinical practice experience with this medication as well. So being in this class, as a refresher, acetylcholinesterase inhibitors prevent the breakdown of acetylcholine. Okay, and it's theorized that a deficiency in acetylcholine in the brain leads to certain forms of dementia, Alzheimer's, as well as potentially a component of Parkinson's type dementia as well. So with that, with this drug, we're trying to prevent the breakdown of that acetylcholine and increase concentrations in the brain and potentially help manage the symptoms of certain types of dementia. Very, very important to remember that this drug does not reverse dementia. So sometimes that's an expectation of patients, caregivers, friends, family, that dementia medications can potentially help reverse this, or they'll be totally 100% back to normal. And we know from the studies and evidence that that's absolutely not going to be the case. So definitely coach and educate patients that this isn't going to reverse their dementia, and they're not going to be totally back to the way they used to be. However, if we can give them a little bit more capacity for memory and some of the symptoms that go along with dementia, that can certainly be helpful and be comforting to some there. So that's the mechanism in short there. Dosage forms, this is kind of one of the big differences with donepezil as far as the class of acetylcholinesterase inhibitors. Rivastigmine is available as an oral formulation, and it's also available as a patch. So clinically, what's the difference? What's significant between these two formulations? So first off, oral, cheaper. It's going to be much, much cheaper than the patch formulation. So that is obviously a big advantage, and if the patient tolerates the oral formulation, that's great. The potential advantage of the patch is if the patient can't swallow or has difficulty, and we feel that they still benefit or they may benefit from this medication, the patch is an option there. Much, much more expensive is definitely a disadvantage. There is also some evidence that may indicate there's less GI upset, diarrhea, and GI risk in general with the patch formulation, which does make a little bit of sense. If we're not giving it through the GI system, maybe there's some irritation and things like that from the oral agent specifically. So potential less GI risk. Obviously, if somebody can't swallow very good, that may be a situation where the patch might be beneficial there. That's also a point at which we might reassess if we want to continue dementia medications altogether. If they're at that point in their stage where they can't swallow and maybe their function is getting even worse and declining, do we want to, spend more money on medications that maybe they really aren't providing us that much benefit? So definitely a good time to reassess if what we're doing is helping and worthwhile to continue. Some cases it may be, in other cases it may not be. Adverse effect profile. So I kind of talked about the GI risk a little bit. In clinical practice, things I've definitely seen stomach upset, nausea, diarrhea along with that. And if we think about that intuitively, so anticholinergics will have directly opposing effects to acetylcholinesterase inhibitors. So if anticholinergics, let's say a diphenhydramine, causes constipation, we can probably anticipate that an acetylcholinesterase inhibitor would cause diarrhea, the opposite action. Same thing with urinary retention. Anticholinergics cause those adverse effects. Acetylcholinesterase inhibitors may be a little bit more likely to cause urinary incontinence symptoms. So couple of things to look out for there. Rarely, I have seen these agents, this class of agents, contribute to bradycardia. So that is something I'll take a quick look at their pulse, make sure that we're not dipping it too much there. Other adverse effects, I've seen sedation, I've seen insomnia, so it might be hit or miss there. I've also seen psychiatric changes. And with dementia patients, it's really difficult sometimes to know whether it's a new medication, whether it's progression of their disease, whether it's a new medical condition that they, can't maybe relay that to you, what they're experiencing. So it can be very, very difficult to figure that out, what's causing what. But whenever we start a new medication or increase a dose, we've got to think that there's the potential for side effects, and sometimes some unique things happen. One, last important thing I wanted to touch on was monitoring. So obviously we're probably going to follow patient's cognition, and is this drug helping in any capacity? Weight loss risk. So this drug definitely is one, along with other acetylcholinesterase inhibitors, that can cause drug-induced weight loss. So I definitely do keep tabs on that, and if I notice, reports of patients needing more supplements and they're becoming frail and that type of thing, not eating, I definitely take a peek at any dementia medications, particularly the acetylcholinesterase inhibitors. And then that bradycardia risk, I do, as far as monitoring goes, I'll take a quick peek at that and make sure it's not, below normal type of thing. All right, so let's take a quick break, and I will wrap up with drug interactions. If you're in the market for pharmacist board certification study materials like NAPLEX, pharmacotherapy, ambulatory care, MTM certification, or geriatric certification, definitely go check out meded101.com/store. In addition, if you're a nurse practitioner, physician's assistant, med student, physician, we've got great books on clinical pearls, medication management, case studies, things that I've seen in clinical practice. I've shared them in many books as well. So go check that out. All those links are at meded101.com/store. And at this point, we do still have the free offer available through audible.com. So again, links are on meded101.com/store. If you've never had a book through Audible and want to give it a shot, I've got 3 books, a couple of 8-hour books, and one newer 10-hour book on drug interactions. You can absolutely get that book for free as long as it's your first book on Audible. So definitely go take advantage of that. Free education, multiple hours of education, a lot of time that I put in to create those resources. So go check those out. And those are available on Amazon.com as well in ebook and paperback too. All right, so let's finish up on drug interactions. First thing I think about with dementia medications specifically is I look for medications that can cause confusion and worsen dementia symptoms. Okay, so anticholinergics, benzodiazepines, maybe opioids even. Think about those drugs that can maybe cloud the mind and exacerbate symptoms of dementia, and they may oppose the potential benefit from an acetylcholinesterase inhibitor. Probably most specifically, anticholinergics are going to directly oppose the potential benefits from acetylcholinesterase inhibitors. So definitely remember to take a peek at those. So the ones that come to mind, tricyclic antidepressants, more so probably older antihistamines, such as your diphenhydramines and your hydroxyzines I see occasionally. Those are all classic examples of anticholinergic agents. I do think about pulse and medications that can lower pulse. So I'm thinking about beta blockers. I'm thinking about calcium channel blockers like diltiazem and verapamil. Those are all meds that could potentially have additive effects on causing bradycardia. And then one last interaction I definitely wanted to mention was there may be an increased risk for extrapyramidal symptom adverse effects from antipsychotics and other dopamine blocking agents. Metoclopramide is another one that comes to mind. So this is something to keep tabs on, because I will say I definitely have seen a fair amount of antipsychotic use in dementia. That's one of the things as a consultant I've worked to try to reduce in long-term care facilities and assisted living facilities. It can be a challenge to do that, but with these dementia medications, there is the potential that we may exacerbate that risk of EPS side effects from those antipsychotics or other dopamine blocking agents. So when we start a drug like rivastigmine, definitely think about that. And if they're on an antipsychotic for some particular reason, keep tabs on movement disorders, increase in maybe tremor and that type of thing, increased risk of falls, and recognize that there may be this slight potential exacerbation from the drug in worsening those adverse effects. Now, the dose of the antipsychotic is definitely going to play a significant role as well. I've seen lots of mistakes there where we've started with way too aggressive of a dose of an antipsychotic, so that can be a challenging and a big factor as well. But definitely recognize that a drug like rivastigmine could increase that potential for EPS effects. That's going to wrap it up for today. Go sign up for our mailing list at reallifepharmacology.com. You'll get a free 31-page PDF, lots of good stuff in there on common clinical practice pearls with the top 200 drugs. If you enjoyed the podcast today, found it helpful, leave us a rating and review. We greatly appreciate that, and certainly helps us grow the audience of listeners as well. Send an email, send a text message, share a link. Definitely share the podcast with classmates, friends, maybe your precepting students, whether you're a nurse or pharmacist or physician. Definitely share the podcast and give students and other healthcare professionals a way to pick up a few clinical practice pearls while they're doing other things, whether it's exercising or getting ready for bed or whatever the case may be. So don't hesitate to share the podcast there. If you've got questions for me, want to reach out, you can find me at LinkedIn, of course, Eric Christensen, PharmD. You can also track me down by hitting the contact button at meded101.com. I'm going to sign off for today. Thanks so much for listening, and I hope you have a great rest of your day.